Hello. Today we'll be discussing the latest updates in renal cell carcinoma. We'll talk through updates in papillary renal cell carcinoma. And in clear cell, we'll talk about some interesting therapies with Belzitufan. And in addition, we'll talk through some of the latest upfront data in clear cell carcinoma, including Cabo-Nivo data and Len-Pem data in the front line. And we'll analyze what might be the optimal strategy in the front line. So to go over papillary renal cell carcinoma, SWOG 1500 was presented by Monty Paul at the latest ASCO GU just last week. And as we know, papillary renal cell constitutes just 15% of renal cell carcinomas. Current standard therapy involves VEGF inhibitors and, generally speaking, sunitinib, but these studies are very small and show about between 0 and 24% response rate with the shorter progression-free survival. So there really is we haven't moved the needle on standard therapy. In addition to that, MET is thought to be a relatively common driver mutation in papillary renal cell carcinoma and is, generally speaking, greater in type 1 and type 2, so potentially represents a target. So in that vein, several targeted therapies that have the potential to inhibit MET were evaluated. And this was initially a 4-arm study involving metastatic papillary renal cell carcinoma. And patients were randomized 1:1:1 to sunitinib, cabozantinib, crizotinib, and savolitinib with a futility analysis looking at crizotinib and savolitinib. And when in December 2018, crizotinib and savolitinib were deemed futile, the evaluable arms included sunitinib and cabozantinib. The primary endpoint was progression-free survival, with secondary endpoints of overall survival, response rate, and adverse events, with exploratory analysis looking at MET. So what was found, the results showed that was a positive study that cabozantinib improved progression-free survival over sunitinib, where the median PFS was improved from 5.6 months to 9 months, and the hazard ratio was 0.6. In addition to that, the response rate was enhanced with cabozantinib, where the overall response rate was 23% in this patient population versus 4% with sunitinib. So generally speaking, cabozantinib resulted in both a progression-free survival and response rate benefit over sunitinib. There was no statistically significant overall survival benefit, although there was a trend in that direction where sunitinib had a median OS of 16.4 months versus 20 months with cabozantinib. So in conclusion, SWOG 1500 is the first exclusively papillary renal cell carcinoma study, randomized study to complete accrual. It did meet its primary endpoint of progression-free survival benefit. And in addition, Cabo had a higher response rate than sunitinib. Savolitinib and crizotinib were terminated early for futility, and cabozantinib really does become the new reference standard for papillary renal cell carcinoma. Now, moving on to clear cell carcinoma. So we know VEGF inhibitors and checkpoint inhibitors as the clear standards within clear cell carcinoma, but the question is what's next? So there's Belzitufan is a small molecule HIF-2 alpha inhibitor. The target being HIF-2 alpha, which is constitutively activated in the vast majority of patients with clear cell carcinoma, as 90% are found to have a pathogenic VHL defect. And this represents a potential target for new therapies. So this study, presented by Todd Bauer from Sarah Cannon at ASCO GU also last week, was a phase 1/2 study. Patients had to have previously treated clear cell carcinoma, and for 4 weeks there was dose escalation cohorts And then patients got 120 milligrams a day in the dose expansion cohort. And this is what was evaluated. The median follow-up was 28 months, and 20% at the time of presentation was still on treatment. The important thing about this patient population was that it was, generally speaking, a intermediate and poor risk population with 76%. And then it was a pretty heavily pretreated population with 62% having at least 3 lines of therapy. What was found was that all-cause adverse events were, this is all-cause adverse events that were greater than 20%. And for the most part, there was on-target adverse events of anemia and hypoxia that you can see in this table, with grade 3 representing grade 3 anemia at about 27% and grade 3 hypoxia that was 16%. Generally speaking, though, other manageable toxicities that are listed, including fatigue, dyspnea, nausea, cough, vomiting, dizziness, headache, and some GI toxicity, generally speaking, all grade 1, 2 adverse events that for the most part are somewhat manageable. The response rate was found to be 25%, which is, again, in a pretreated population, is favorable. And you can see that this was both in both the IMDC favorable risk and intermediate and poor risk patients had responses. And here's the waterfall plot showing that 64% of patients had a reduction in the target lesion size. And the PFS of this patient population was 14.5 months. Again, a pretty heavily pretreated population. 35% continued on treatment beyond 12 months. And median the duration of response was not met, with 71% responders having a greater than 6 months response. So in conclusion, Belzitufan had manageable safety profile, with anemia and hypoxia being on-target toxicities. And again, in this heavily pretreated patient population, there was a 25% response, with the median duration of response not reached at 28 months follow-up. 71% responded for greater than 6 months. So this validates the growing preclinical and clinical evidence that HIF-2 alpha inhibition is a potentially emerging treatment for clear cell carcinoma. There's phase 3 trials ongoing against reference standards, including everolimus. In addition, at ASCO GU, Tony Chiari presented a phase 2 study of Belzitufan with cabozantinib, showing a 22% response rate in this previous IO cohort, with durable disease control, but not clear what the applicability is in combination with cabozantinib. But one thing is clear is that this HIF-2 alpha inhibition is clearly a potential target for the future in clear cell, and we look forward to ongoing data as it emerges. Now, moving on to frontline clear cell carcinoma. This is a very active space, and as of late 2020, there are really 2 options showing improvement over sunitinib. One was CheckMate 214, showing ipilimumab with nivolumab, which enhanced response rate and survival and PFS. And the other was axitinib with pembrolizumab, Keynote 426. And again, ipi-nivo in the intermediate and poor risk, and axi-pembro in all risk groups, but clearly showing a significant benefit over sunitinib and changing the landscape. Now I'm going to present both CheckMate 9er from fall 2020 virtual ESMO, and as well the clear data with lenvatinib pembrolizumab from GU ASCO just last week. So this is CheckMate 9er. So patients were frontline clear cell carcinoma. They were any IMDC risk group. Patients were randomized to nivolumab at 240 and cabozantinib at 40 milligrams, so a reduced dose from standard 60 milligrams in this combination. And this patients were randomized to that versus standard dosing of sunitinib with 4 weeks on, 2 weeks off. Primary endpoint was progression-free survival. Secondary endpoints was overall survival and response rate, and as well as safety. And you can see clear progression-free survival benefit. It almost doubled progression-free survival from 8.3 months to 16.6 months. And overall survival as well had improved significantly with a hazard ratio of 0.6, but the median OS not reached in either arm. But clearly you can see the Kaplan-Meier curves are quite impressive. In addition to that, response rate was enhanced from 27% to 55.7% with Cabo-Nivo. And with 8% complete responses to Cabo-Nivo, and 48% partial response. So disease control rate had improved from 69% with sunitinib to 88% with Cabo-Nivo. And you can see that the progression-free survival was improved in the Cabo-Nivo arm with every pre-specified subgroup, including of importance, even favorable IMDC prognostic risk. You can also see, just to highlight, that bone metastases had, as previous reports of cabozantinib showing particular effect on bone metastases, you can see that there's an enhanced benefit. But generally speaking, every subgroup derived the benefit. And overall survival, not as clear, but you can see favorable, not as clear. And then if you look at duration of therapy, patients, generally speaking, were on Cabo-Nivo more, largely because they didn't progress as frequently. But notably, only 3.1% of patients actually came off of Cabo-Nivo, off of both therapies, which we'll discuss in a bit. Of the adverse events, you can see that for the most part, Cabo-Nivo didn't really add too much to the level of toxicity when compared to sunitinib alone, except for a little bit more diarrhea and a little bit more LFT abnormality, which could be managed with dosing alterations. In addition to that, and importantly, patients had improvement in quality of life and disease-related symptoms, which was a unique differentiator with Cabo-Nivo. Okay, now moving on to the CLEAR trial. So this was presented by Dr. Motzer at ASCO GU also just last week. Patients were this was a frontline study with clear cell carcinoma. Patients were randomized 1:1:1 to lenvatinib pembrolizumab, lenvatinib at a high dose of 20 milligrams to lenvatinib at a slightly lower dose of 18 milligrams with everolimus versus sunitinib as the reference standard. Primary endpoint was PFS with OS, response rate, safety, and quality of life as secondary endpoints. And there was over 1,000 patients randomized. And you can see that as far as progression, that lenvatinib with pembrolizumab improved progression-free survival significantly over sunitinib from 9.2 months to 24 months. And lenvatinib everolimus was actually also better than sunitinib alone. And it improved to 14.7 months. But clearly lenvatinib pembrolizumab had a much better hazard ratio. And you can see here that this was the progression-free survival was improved in all pre-specified subgroups. And overall survival was also enhanced with a hazard ratio of 0.66 with lenvatinib and pembrolizumab versus sunitinib, with the median OS not yet met. However, as you can note in the Kaplan-Meier curve, at some point 2-3 years in, it's not clear what happens with the crossover of the curves. The objective response rate was enhanced significantly with lenvatinib with pembrolizumab showing a 71% response versus sunitinib at 36%, 71% quite impressive, perhaps the best in any phase 3 study to date, and an impressive complete response rate at 16%. In addition, the duration of response was enhanced from 14.6 months to 26 months with lenvatinib and pembrolizumab. The median duration of response was also enhanced from 7.8 months to 17 months, as noted. And in addition to that, you can see that the combination of lenvatinib with pembrolizumab was patients came off of study due to treatment-related AEs at a higher rate than you might expect. Patients had 72% treatment-related adverse events on lenvatinib and pembrolizumab. Notably, if you look at this chart, you can see that there was significant increase in treatment-related adverse events, including diarrhea, hypertension, hypothyroidism, decreased appetite, proteinuria, rash, and dysphonia over the sunitinib alone that seemed to be an enhanced side effect, likely from full dose of lenvatinib. So in conclusion, to kind of summarize both the CLEAR and CheckMate 9er for frontline clear cell carcinoma, both lenvatinib, pembrolizumab, and cabo-nivo demonstrated significant improvements in PFS, OS, and response rate over sunitinib alone. Lenvatinib and pembrolizumab had the highest response rate at 71%, had the highest complete response rate at 16%, and the best PFS hazard ratio. Cabo-nivo had the best OS hazard ratio at 0.6 and had definitive quality of life improvement. Lenvatinib, pembrolizumab seemingly had additive adverse events, including more diarrhea, hypothyroid, proteinuria, and dysphonia. And of note, the treatment stoppage of treatment due to toxicity was more with lenvatinib than with cabo-nivo, clearly, lenvatinib pembro. So, and maybe that was an effect of the higher dosing. Maybe it was effect of the drug, and clearly they were manageable toxicity, but patients came off of study more for toxicity. So both great new standards, but it's really unclear which combination is the clear winner. So additional take-homes are SWOG 1500, cabo showing clear PFS benefit with a higher response rate of 23% versus 4% over sunitinib in papillary RCC. And cabo is clearly the new standard for papillary RCC based off of this. In addition to that, we have a potentially emerging therapy with phase 1/2 data with Belzitufan, with a manageable safety profile with anemia and hypoxia as unique on-target toxicities. And in this heavily pretreated patient population, this phase 1/2 study showing response rate of 25% with a long duration of response is quite impressive. And we look forward to additional data on this as it emerges. Thank you so much.